Uh, there we go. Thank you, Jen. Appreciate it. So thanks everybody for joining us. And so sorry about all the technical difficulties, but appreciate all of your patience. We have Dave Gustafson on today. My name is Megan Ringo. I believe everybody knows me at this point. But thank you for joining as part of the Wisconsin-Rose Lunch and Learn series as part of the Wisconsin Rural Opioid and Stimulant Engagement Project, which focuses on addressing prevention, intervention, and recovery of opioid and stimulant use disorders in rural communities. And it's funded by the Rural Opioid and Stimulant Engagement Grant from SAMHSA. So if you were unable to register via the Zoom invitation I previously sent, please message me your name, email, organization, and coalition affiliation so we can better track our records. So I will have Dave, I'll pass it over to him for his presentation on innovative approaches for rural community actions to address substance misuse.
Well, I have a 2-hour presentation. No, I don't. Thanks for the opportunity, and we're a little short on time now, aren't we? So that's gonna. So I'm gonna try to go through it as well as I possibly can in the time that's available. Yeah, go to the next slide. Yeah, what I was thinking, one before that, please. Yeah, there you go. Nope, next one. There we are. Yeah, so I was going to do an introduction, but I think that there's a lot of people on the screen, so I'm going to pass on that. And then I'm going to talk about who we are, then talk about alcohol and drug abuse in rural America, then talk about our smartphone systems, talk about the results of a pilot test and implementation research, and then just sort of raise the issue of what might potentially be the role of extension in all of this kind of stuff. Next slide, please. Our research center is called the Center for Health Enhancement Systems Studies. The 2 red circles at the bottom talk about what our methodologies are for our research. One is that we, on the right-hand bottom side, we do a lot with technology, smartphones, laptops, Alexa kinds of, voice activated speaker systems and the displays that go with them. And then we get a lot into implementation, how you implement that technology, also how you implement other kinds of improvements through quality improvement. And our research is really focused in 3 areas: addiction, aging, and in cancer. Next slide, please. Our center is fairly large for a university research center. We have about 53 researchers that are located, thank heavens to Zoom, around the country, ranging from Puerto Rico to Texas to California to, well, and of course, Wisconsin and the upper Midwest. And the box in the center here is a box that really sort of shows you our methodologies that we use. Systems engineering is sort of the centerpiece of our work, but we have, faculty from communication sciences, from nursing, from psychiatry, from computer science, addiction medicine, healthy minds, all sorts of places. And we do research in a variety of areas. Some of them are addiction treatment agencies like the S-Star you see, and down on the bottom right part of the black screen, APT and out of Yale. And we do a lot with the clinical trial networks and things like that, and have a lot of different projects. I would have gone into them, but I'm not going to go into them. Just to mention that one, for instance, is with the Eastern Shoshone in Wyoming, and we're implementing statewide in Iowa, and then a lot of activities here in Wisconsin. Next slide. A little bit about substance abuse. First, you guys probably are well aware of the problems in rural America, especially among youth who are heavily engaged in alcohol abuse. Compared to other parts of the state, a lot more binge drinking, cigarette smoking, smokeless tobacco use. Marijuana and illicit drugs are not as common, but in the other areas, it's a pretty significant issue. Next slide, please. And as I said before, our research is based around various kinds of technologies. Our one system that we have, because I do want to concentrate on substance abuse now, is HESS. CHESS stands for Comprehensive Health Enhancement System Studies, and the A means addiction. And so next slide. And HESS is, as I say, smartphone system that what we try to do is three things. First thing we try to do is find a way to allow people anonymously to talk with other people who are going through the same stuff they're going through. Second thing, to motivate them to keep on keeping on. And the third is to give them a series of tools that they can use to try to cope with their addiction. And then I didn't mention a fourth, but it's becoming more and more important, and that is the collection and sharing of data about how the patient is doing over time. Our HESS system has these services, as you see on the right-hand side, a profile, so you can figure out the characteristics of other people, even though you won't know their names, that are on the system. They can private message among themselves. They can go into discussion groups. We have a panic button that allows them, if they're really in trouble and need help immediately, takes them to a series of tools that sort of distract them from what they're going through, while a message, call for help, is sent out to their close supporters. There's various kinds of skills training, and there are various kinds of events that we hold, and just a lot of quick tips and surveys and that kind of stuff. Next slide, please. One of the things that we've found that we've gotten more and more into is finding ways to share the information we collect with the clinical team. And so on the right-hand side, you'll see that we collect information about 8 different things. How are they managing their pain? How are they doing with their balance, their mood, their quality time with other people, their thinking and memory, their healthy meetings, their physical activities and sleep. And then in addition, when we get into the addiction stuff, how much they have been using over the past week. And you can see on the right-hand side of this screen that we can track how things have gone on over time. Now, the reason why I'm concentrating on the right-hand side is because the left-hand side didn't work. The left-hand side was much more detailed information that the clinical team could look at to see, you know, for instance, the red dots, if we were to click on them, would say what key events seem to be occurring at those points in time, and they could see all sorts of other information. The problem with them was the clinicians would say, I'm too busy, I don't have time to look. So what we did was we developed a screenshot that takes about 10 seconds to look at. And it covers all of the various kinds of things that people are talking about. And so they can see, for instance, that sleep hasn't been doing particularly well of late, and things are going better with spending time with the other people and things like that. But it's a way to let clinicians know what's happening to the patient in between clinical visits. Next slide, please. And when we tried out HESS, we found it worked pretty darn well. We looked at how patients were doing at 4 months and 8 months. We took away the HS and looked at what happened 4 months later. And the red bars are for the control group. About, I think, 349 people were in this particular study, and half of them in the control group and half of them in HS. And you can see that if you look at the, the performance of the two systems, the control group was much worse. And if you look at the differential between the control group and the experimental group, you see that over time, even after you remove the technology, the difference between the two systems, between the control group and experimental group, continues to widen. And so, that was a very exciting kind of outcome that occurred. And from that, we carried out a lot of research in various kinds of ways. Next slide. One of the, for instance, let's go back to the previous slide for just a second. Other research that we carried out was we went into Appalachia and gave HS to about 100 women of childbearing age who were addicted to either alcohol or drugs. And we found that that patients who got access, the people who got access to HS stayed in treatment much longer, twice as long, and received twice as many services as people who didn't. So they're pretty, and we've looked at this, we've looked at what happens if you give HS to people on opioids, and what happens if in dealing with opioids, there are now a lot of medications that can sort of help control opioids. But we found that if you add HS on top of the medication-assisted treatment, that some interesting things happen. For instance, less use than the medication treatment alone, less use of emergency rooms, less use of the medications, and less use of the drugs and things like that. So, HS seemed to be pretty interesting. But then we did a study in lung cancer. And in lung cancer, we didn't try to do anything for the patient. All we tried to do was to help the family caregiver of a lung cancer patient cope more effectively. So we taught them how to be a better caregiver. We taught them how to say goodbye to the patient. We gave them all sorts of information and guidance and support. And strangely enough, we found that the patients lived 40% longer when they were given access to a technology, when their caregiver was given access to a technology to help the caregiver do better. So the patients lived longer, they suffered less, and the stress on the caregiver was less. And we started thinking, maybe this is really important. Maybe we ought to be trying to look at what happens if we develop a family-oriented intervention rather than a patient-oriented intervention. Now, next slide. So we contacted a group at the University of Massachusetts run by Beth Epstein, and she had developed this system for training couples on how to function more effectively together and to cope jointly with their addiction problems. And it was a very successful system, except nobody used it. And the reason nobody used it appeared to be the stigma that was associated with having a partner get engaged through an addiction treatment agency. They just did not want to go to an addiction, the partner did not want to go to an addiction treatment agency. And since it was a face-to-face therapy, that pretty much put the kibosh on it, and it never had received any kind of real-world implementation. So we thought, okay, well, what would happen if we combined alcohol behavioral couple therapy with HS? And so we could then develop a system that might be able to perform a little bit better, because you'd be training the family members on, for instance, what do you do if your loved one comes home drunk? What do you say to him? How do you communicate with him? What do you do? For instance, we advise them just to get out of the house for the night and come back the next morning. But anyway, we gave them various kinds of tools that they could do things like understand the triggers that are likely to be causing problems, maybe interface with the patient before they actually start drinking, teach the drinker themselves to be willing to interact with their loved one about their condition when they're feeling cravings, and all sorts of things to help the family cope with the disease more than just the patient. And let's go to the next slide. And the system we came up with is one that has various parts to it. And I'm going to go over some of these things to highlight stuff. For instance, one of the things we have are these collaboration tools that the couple can use, cravings discussions, dealing with triggers. What do you do if somebody relapses? A link that the partner has to help, sort of a panic button kind of thing. And then there's the dashboard that we talked about earlier on the right-hand side. Then going down the middle to social support, we have various kinds of things now, a Zoom thing so that groups can get together and talk. Sometimes they show their faces, but not typically. Normally they'll just use Zoom, but without showing their faces. Private messages, various kinds of things of that type. And then the self-monitoring, the check-ins and things like that. And then information resources. So we teach them how to relax. We have personal stories of people who are going through the same thing that they're going through, so they can learn from each other. And then we use some of the special capabilities of phones. One, for instance, is the GPS systems. You can track the location of the patient. And so at the beginning, when they first get on the system, they can type in, for instance, the name and location of the bars that they used to frequent. And so that if a patient approaches a bar and stays there for 5 minutes, a warning comes out, and it might be a self-recovery warning where, for instance, they have videotaped a message from their daughter, and the daughter says, "Daddy, please don't do that, come home," or other things like that. And then that warning and recovery reminder will pop up on the screen. And then if they stay there for another 10 minutes, then a call goes out to their support group to say, "Hey, this guy's clearly in trouble. Why don't you try to help him?" The same kind of thing is available in terms of using the same GPS system to track when they go to their addiction treatment programs like 12-step meetings and that kind of stuff, so that if they are in treatment, the treatment people can see whether they're not, they as an addict are coping or trying to do their best to also participate. So, the left-hand side shows you what the system looks like on a smartphone. It's just these buttons, and each one of these covers one of these areas here. Next slide. Now, before I get into talking about a small pilot test that we've just conducted and the results of it, let me stop here to see if there are any questions about what HS is, or what PartnerCHESS is, or what it's trying to do, or how we're trying to do it. What questions do you have?
I'm sorry, I got pulled away. This is Donna, and I'm just wondering, can anyone do this, or do you have to be in therapy and with a specialized therapist to do this, to utilize this?
The way in which it has run so far, but that's a really important point, Donna, and I'll get around to answering it with this preface. Up until this point in time, yes, you had to be referred by a treatment provider. And the reason for that was to try to protect the privacy of these folks. We didn't want people coming in from anywhere and harassing them and things like that. And so we've had to do a variety of things. For instance, a person has to sign an agreement that they're not going to get snotty on the system and that kind of stuff. And currently, the only way you can get in is through a referral from a provider. But in a second, I'll show you what's happened in that direction. So sort of a great question leading up to the next part. Sheila, did you have a question or a comment? I guess.
Nope, I'm good.
Okay, all right.
Tamara did. She said, how current is the research?
How current? Did I hear that correctly? How
Yes.
current?
How current is the research?
Well, we're still going on and doing this stuff. You know, we have, golly, several $1 million worth of research going on these days on this system. One of them, John Curtin, one of my colleagues in psychology, is developing a way to predict relapse so that we can intervene in very quickly to try to prevent the relapse. It's using various kinds of machine learning and that kind of stuff. So we're always sort of trying to improve the system and to make it sort of continuously better. And we've got now a very large test of the PartnerCHESS program, which I'll get into in a second, that's going to cover probably about 600 patient families around the country and that kind of stuff. Let me go ahead then, and I'll just move ahead. Thank you for your questions and comments. When we first developed this system, we didn't have any idea whether it would be as successful as the lung cancer program was concerned. And so we got a small grant from the feds to just get 35, we intended to get 34 dyads, drinker and romantic partner. We got 35, but anyway. But it's interesting, and it goes back to Donna's question. When we first started this particular study, we tried to recruit patients from treatment agencies, and we found that we weren't getting anywhere, that you just couldn't. The treatment agencies are not a good place to try to recruit families to cope with this particular problem. And so, crazy enough, we went to Craigslist and other places like that. And within 2 weeks, we had 35 couples sign up saying, yeah, I think I need some help here. And we randomly, so, you know, the bottom line for that is maybe we don't even need treatment agencies. Maybe all we need to do, if this thing works, is to send out in mass media ways to recruit. And in our big study that we've got coming up now, soon you'll see advertisements on Fox television and on various kinds of radio programs and things like that. We're figuring that we can get people who otherwise would never seek treatment. And by the way, 80% of the people who are addicted to alcohol never seek treatment, 80%. And so in this particular small pilot, we took our 35 dyads and we divided them randomly into two groups. One group got the HS system, which was, as I showed you earlier, is an evidence-based practice. It works pretty well. And then the other 18 got PartnerCHESS. And in this very small pilot, we tracked people for about 6 months just to see if there was any reason to believe that there might be reason for hope. Next slide. And even though HS was an evidence-based practice that made a big difference in the lives of patients, it turned out it wasn't nearly as effective as PartnerCHESS. Let's go to the next slide. For instance, one of the things we found was that the use of PartnerCHESS was much higher than the use of HS. HS is the red things down at the bottom, the dots, and you can see that over time, this was a 6-month study, so about 25 weeks. And over that time, you saw a reduction. Started out at about 2.5, maybe to 3 times a week that they'd get on, and went down from there to about once every 2 weeks. Whereas if you look at the patients in the PartnerCHESS part of PartnerCHESS, which is the blue triangles, you see that the patients in the PartnerCHESS program use the system a lot more than the people who were out there, the people who were out there alone through HS. But interestingly enough, the partners used the system even more than the patients did. And that's going back to the lung cancer thing that suggests, wow, you know, maybe if you help the partners, you really help the patient a lot. Now, there is a decrease, as you can see, over time. But even after 6 months, you still had people in the PartnerCHESS program going on somewhere around, what is that? Maybe a little more than, somewhere between 1 and 2 times a week. So they were still engaged with the system. Next slide, please. But the results were really pretty interesting in terms of effectiveness. And, you know, we looked at a variety of kind of things, but a good example is if you look at the bottom left-hand screen of the bottom left-hand part of the screen, you'll note that when the people first came onto this system, about 90% of them were heavily drinking every day of the week. You know, so I mean, you had a lot of alcohol abuse where they were drunk virtually every day of the week. And once you put PartnerCHESS into place, you started immediately getting things better. You know, by 2 months, about 25% of the people had no risky drinking days at all over the previous 6 months. And by 4 months, about 55, maybe closer, yeah, about 55% had no risky drinking days. And by 6 months, when we stopped the project, 74% of the people had gone from drinking virtually every day to no risky drinking days at all in the previous 2 months, which we thought was pretty startling. You know, I haven't seen anything even close to that through formal treatment or anything else. And so it seems like there's something going on here. Next slide. Now, the next thing that I'd like to, I'm looking at the time. I think I'm going to pass on this, except to say that, yeah, let me pass on this. Go to the next slide. And the next slide, pass over this too. I think that dissemination is a big deal. We have tried various approaches to implementing HS and not HS, but another system we have for older adults that it focuses on Wisconsin. And what we did was we contacted community librarians throughout the state, and we got 53 of the 72, I guess it is, counties in the state to agree to offer a system, not PartnerCHESS, but offer a system trying to help older adults cope with their multiple chronic conditions. And we got things going to some extent in all of these counties, and then our grant money ran out. But you know, we have been for a long time. The point of this whole thing is for a long time we've been interested in trying to reach into fairly rural parts of our state and make a difference. Next slide. So a couple of things that have happened, of course, not doing it in proper order. If you go down toward the bottom, one of the things that just recently started to happen, really because of the virus, is that Medicare and Medicaid have started paying for treatments that are provided virtually through systems like HS. And so people can now, not in Wisconsin, but in many states around the country, can now start billing Medicaid and Medicare for getting access to systems like CHESS. And so we did, going to the top of this slide, you know, we did this pilot dissemination in rural communities around Wisconsin. Now we have a study that's going to go full bore and trying to recruit about 600 patients around Wisconsin, but also a little bit beyond it. And we're working with our clinical trial network friends in Minnesota and in Chicago to have a fairly wide dissemination. And you know, our question is, are we going to be able to do a better job of reaching people in various parts of the country, not only Hispanics and Native Americans and African Americans, but white people and in rural counties, and see what would happen. Will they adopt these systems? Will people in rural areas use them? And our thinking is that if we work with the various structures that exist in these parts of America, public health services, family services, churches, Tavern League. But for me, one of the most important potential is in the area of, you know, is this a role that Extension needs and could be playing? You know, Extension comes as no surprise for you guys to hear, has had such a powerful impact on rural America. And certainly here in Wisconsin, that's the case. I don't know what's going on right now in Extension, but one question that one might be inclined to look at is, you know, after the infrastructure bill that was just passed by Congress a few months ago, you know, we're going to have much faster internet throughout the state of Wisconsin. And already about 80% of the people in rural Wisconsin own smartphones. But there are some blank areas in the state, and there's not a lot that's going on in those areas. But a question in my mind is, you know, is this a role for Extension? They've reached out in so many ways to help people, and maybe reaching out into the addiction area might be something that they would want to engage in. And maybe one way of reaching them, and also taking a look at the future of Extension more broadly, is to begin to use technology. Maybe you already are using it, but using technology to get at these issues. So I've got 2 minutes left, And I don't have anything else to say, so I'm going to just twiddle my thumbs and see if you guys have what questions you have and what else needs to be discussed.
There's a question in the chat. Can we refer participants for the study?
For the new study coming up, absolutely. Absolutely, you can. Remember, it will be a randomized trial, so half of them will get HS and half of them will get PartnerCHESS. Well, that's not true. A third of them will get HS, a third will get PartnerCHESS, and a third will be put into a control group. In each of these cases, we'll be giving computer devices to the patients. In the control group, they won't get anything other than the computer, but they'll get internet access and that kind of stuff. But absolutely, Jen, we'll reach out to you as soon as we're ready to go. It's going to be another few months before we get started, but yes.
So yeah, so as soon as they're not recruiting participants right now, but they will be recruiting later, and we'll get you all the link for that. Is there a link to share yet about the about this project or more information about HS?
Probably not about PartnerCHESS. I could certainly give you access to articles, in cancer, in older, in multiple chronic conditions, and aging, and that kind of stuff, and give you access to a few papers if you want to, sleep better at night. You could start reading one of those suckers, and before you know it, you'll be snoring. So I'll send you a few links, Jen.
That'd be great. There is a question, is this for alcohol only?
No, the system that we have up right now is one that is alcohol only. We have a system that we're in the process of developing that will be for polydrug users. So people who are on, cocaine, methamphetamines, but also on alcohol or also on opioids or things like that. That system is in the process of being developed at this point, but it won't be ready for testing for probably another 12 months.
Those were all the questions we had on chat. Is there anything else y'all want to ask Dave while we still have him?
Well, thank you very much for spending some time with me. I apologize that we had so much trouble getting on, but anyway, there you have it. So best of luck to you folks.
Well, if you look at the chat, everyone's saying thank you. Everyone thinks that you're doing great work, Dave, you and everyone else at Chess.
That's good. That's good. So we're excited about potential of maybe working with you guys. Talk to you later. Thank you. Bye-bye.
Thanks, Dave. I did also include in the chat that we will have a closed session on May 16th. More information to come on that.